My name is Leah. I'm the webinars officer for the Health Services Research Networking Group. We're so excited that you joined us today and super excited to welcome these speakers. Our speakers today are Dr. Kristen Hohl and Dr. Miriam Rafferty discussing the Implementation Research Logic Model, Framework Introduction and Real-World Application. The session is being recorded. Please mute your mic and turn off your camera during the presentation. We'll have 20 minutes for Q&A at the end. Please go ahead and submit questions that you have into the chat and I'll monitor. I'll go ahead and pass it over to you guys.
Great. Thank you. I am going to deal with screen sharing here.
Yep, while you screen share, I'll go ahead and introduce you guys. It's my pleasure to introduce our guest speakers. Kristen Hohl currently divides her time as a physical therapist, working in a technology implementation role and working in Dr. Miriam Rafferty's KTEAM at the Shirley Ryan AbilityLab in Chicago. Kristen received her Bachelor's of Science in Biology from Denison University in 2009 and her Doctor of Physical Therapy from University of Pittsburgh in 2012. She earned her APTA Board certification in Neurologic Physical Therapy in 2017. Kristen's clinical physical therapy background involves working with individuals with neurological diagnoses and medical complexity across all levels of care. As a leader in the organization, she readily employs evidence-based interventions into her clinical practice. Her research interests include using implementation science to understand the translation of evidence into clinical practice. And Dr. Miriam Rafferty is a research scientist and the director of implementation science at the Shirley Ryan AbilityLab, as well as an assistant professor at Northwestern University's Feinberg School of Medicine in the departments of physical medicine and rehabilitation, medical social science, and psychiatry and behavioral science. She is also an active physical therapist clinician specializing in neurological physical therapy. Dr. Rafferty's research uses implementation science methodology to study the implementation of evidence-based practices and novel technologies into real-world rehabilitation settings. She has grants from the National Institutes of Health, Parkinson's Foundation, and Agency for Healthcare Research and Quality. Pass it over to you guys.
Okay, great. Thank you so much, Leah, and thank you to the Health Services Research Networking Group for having us here to talk about the Implementation Research Logic Model. I'll be starting out today talking about the kind of introducing the Implementation Research Logic Model, or the IRLM, and the learning objectives are to help make sure that you understand the components of it and how it serves to connect multiple implementation science frameworks. And then I'll be passing it off to Kristen to summarize the Rehabilitation Treatment Specification System implementation project at Shirley Ryan AbilityLab and how the IRLM supported that. We will be taking some breaks through as we kind of transition topics. So if you have questions that you're putting in the chat, feel free also, if you have a question, to just chime in, and we'd love to kind of have this be conversational if you have questions. So to kick it off, I just wanted to make sure we're all starting at the same place on what is a logic model. And a logic model is frequently used in grant or project or program planning and evaluation. And it's a structured, normally visual representation of how a program, project, or research initiative is expected to work. A very traditional logic model in a lot of public health program evaluation is here below, where it shows the inputs, the activities, the outputs, and the outcomes. And the logic model kind of illustrates the relationship between these items, with the inputs being the resources that you have when you start a project, like funding or staff or equipment. The activities could be your intervention that you're doing. Your outputs are what you produce. So the number of sessions that were held, what materials were created as a part of the program, and then the outcomes being what changes occur in the short, medium, or long term. All of this kind of happens with some assumptions and external factors of things that might be outside of your control as a program evaluator. But this traditional logic model is difficult in implementation science, in part because implementation science can be a different language. It's its own jargon. And so to make it a little bit easier, a group of researchers at Northwestern University at the time, J.D. Smith, Dennis Lee, and I worked to try to figure out a structure or language that would work for implementation research. So J.D. Smith was really the leader of this, of these efforts, with Dennis and I kind of working. Dennis is works more in a community setting, doing a lot of HIV prevention types of research, and I work in a healthcare setting, and J.D. Smith was a psychology and mental health setting. And so we really tried to bring together different aspects of implementation science and implementation research together and see how this would look. So the idea of the implementation research logic model was to provide a roadmap for how an implementation project could be expected to achieve its goals. And it's useful to help plan, implement, and evaluate a project. And the idea with this is that it would improve the rigor of implementation research through a common language and structured approach to developing a logic model. The idea when we developed it was to help facilitate communication with grant reviewers, with paper readers, with other implementation researchers, and I think it does that fairly well. I will say that one of the places where it kind of fails is that it does not help communication necessarily with clinicians unless they already also speak implementation research language or our jargon. So we have to be really careful when we use it and how we describe it when we're working with clinicians to make sure that we don't just have them get lost in the theoretical implementation components. So we talked about inputs, activities, and outputs in a traditional logic model. The components of the implementation research logic model are implementation determinants, implementation strategies, and the mechanisms of those implementation strategies leading to implementation outcomes. Also very important would be the clinical intervention and its mechanisms, so understanding those, or community program and its mechanisms, and then the clinical or patient or population outcomes. When we developed the implementation research logic model, this was the initial form of it, where it has the determinants on the left, and the determinants in the initial example were drafted using the consolidated framework for implementation research, which has 5 domains. The intervention characteristics, which are now called innovation characteristics, the inner setting, which in the context of healthcare would be your organization, the outer setting, which in the context of healthcare is kind of the bigger health systems, reimbursement landscape, the characteristics of the individuals who are involved in implementation. So this could be the innovation recipients, so your patients, the deliverers, which could be your clinicians. It can also include health systems leaders as other stakeholders that are really important to implementation. And then within each of these individual groups, these individuals have needs. Patients have different needs than clinicians, but they're both important. Health systems administrators also have a different set of needs. The IT team has a different set of needs. So really understanding the needs and the capabilities of all of the individuals who are going to be touched by the project and the processes. So these 5 determinant domains come from CFIR, but you could use other implementation determinant frameworks to fill up that box as well. The implementation strategies had a box, the mechanisms of those strategies, and then the outcomes being kind of from proximal to distal implementation outcomes, service outcomes, and clinical and patient outcomes. And I'll talk a little bit more about how we fill in those boxes as I give some other examples. I will say, like with this one being our original example, we immediately saw that there needed to be some changes to it. And one of those changes, it can be seen in this example here, that was actually one of the published examples in that article with J.D. Smith. This is an example from my Parkinson's work, looking at an early Parkinson's program. And here we have the implementation strategies, and we were really focused on sustainment, and we integrated the National Health System Sustainment Model, which has splits up kind of sustainment strategies as process-oriented, organization or inner setting-oriented, and staff level-oriented. But what we added to the intervention was an intervention box, the clinical intervention, and making sure we understood the clinical intervention and how that actually kind of creates a line that if people exercise enough if people with Parkinson's exercise enough, then they're more likely to have good clinical outcomes for Parkinson's. That would be a very distal thing. In this particular project, we were really just looking at whether or not the patients exercised or not. So this is just one example. One of the things that was key when we developed the implementation research logic model was to try to link together the strategies, the mechanisms, and the outcomes. And so in this particular example, I do that using color coding, that an implementation strategy, that if we created a specific electronic medical record referral trigger, that would help lead to a specific proactive or consultative PT schedule. It would increase PT referral rates and increase people with early Parkinson's actually going to PT, because the referral would say something about mild to moderate Parkinson's disease, as opposed to being like the patient thinking it would be 3 times a week. It would be just a few visits. And the outcome then that we would want to see is that more medical doctors, the movement disorders neurologists, would refer to PT, and that would be increased adoption. So this is one of those examples that we kind of added a box to it. And I wanted to show kind of some of the other ways that it has been adapted for kind of for different types of projects that we kind of realized as we were writing it. Here's another example of a template that if you were doing a multi-site trial and you wanted to see how the determinants differed between context 1 or site 1 and site 2, and then you could have strategies for context 1 and strategies for context 2. This is really nice in theory. In my particular multi-site study, we were like, wow, this is just not enough room to write all of the different barriers and facilitators under the determinants under context 1 and context 2. So we actually have 2 whole separate implementation research logic models for a multi-site trial, but this would be a way that we could maybe summarize them down if you wanted one visual of how 2 different sites differ. So kind of with that as the background and kind of based on now 5 years of experience using it, what are some of the ways that the IRLM can and can't be used? So where I have found it to be really helpful is to use it in my grant writing and project planning. It really helps you think through some of the things that you might need to do for your project. It helps during those planning stages, whether it's before or after the grant has been written. I like to use it as a pre-implementation outcome of a study aim. So like aim 1 is to get determinants information for barriers and facilitators through interviews or stakeholder meetings. And then after getting that information, we can use it to fill in the determinant section of the implementation research logic models. We can work with our advisory board to help talk through the implementation strategy so that the result of aim 1 is to have a completed implementation research logic model. And we also have used it in reporting the project, so in manuscripts, to kind of describe everything that we considered and everything that was done in the study. But there are ways that it is not useful also. So it is not useful for communicating with clinicians what you plan to do. When our advisory board, they need to be walked through it. We can't just show a picture of the implementation research logic model that looks like this and say, okay, do you guys agree? Does this look good to you? It would just get really lost with, they would get very lost very fast. So we don't use it for communicating with clinicians as a whole. We would break it up into chunks to communicate with them. It also doesn't describe your implementation process. So it can't really be used as an implementation blueprint or plan. You still would need a separate implementation plan to describe what you're doing for your project. So I wanted to kind of dive in a little bit deeper there to the component frameworks that are in the IRLM. And I want to kind of compare that to implementation processes, because I think that's one of the spaces where it does get mixed up a little bit, is because people think, oh, I'll create my logic model and that will help prepare me for implementation. And I'll show how that doesn't always work out. So the components, as I mentioned before, the implementation determinants, the implementation strategies, the mechanisms of actions for the strategies, implementation outcomes, and the clinical or service outcomes. So component frameworks for implementation determinants. I did not put all of the different references for all of the different components. If you're looking for content on all of the different implementation determinant frameworks or implementation strategy descriptions, there's some really good resources through ACRM, through the Learn and Center for Health Services Research and Training that was out of Brown University. They have a number of good webinars on that. So I'm just using acronyms here because I know our audience is familiar with implementation science as a part of the Health Services Research Networking Group. But please feel free to chime in on the chat if you have any questions about anything. So implementation determinant frameworks, some of the common ones I mentioned before, the CFR, the Consolidated Framework of Implementation Research, is the most widely used in rehabilitation. EPIS is another model, the exploration, preparation, implementation, and sustainment, that has a process model to it, but also does have a determinants framework embedded within it. Precede, proceed, PRISM, there's a number of different determinant models. And I think the important part to note is while the draft implementation research logic model uses CFER, you could embed any determinant framework into that section. For the implementation strategies, the most common taxonomy is the expert recommendations for implementing change, or the ERIC taxonomy. There's a lot of overlap then with that taxonomy and the mechanisms of action. Right now, the mechanisms of implementation strategies are not very widely, they're just beginning to be studied, I should say. And there isn't a really widely accepted taxonomy yet, although hopefully soon there will be. I almost use the ERIC taxonomy. There's the original version that's a list of 73 different implementation strategies. And then there's a version where they bucket those strategies into nine different kind of buckets through a concept mapping project. And what they do is they put like everything related to education into one bucket. And so I think that that aspect of the ERIC taxonomy can be useful to drive mechanisms of action. So like education, well, education increases knowledge. So the mechanism of action of an implementation strategy related to education would be that it increases knowledge of the patient or of the clinicians. So the purpose of thinking about the mechanisms of actions, though, is really to get us to the outcomes. And the implementation outcomes, the two most widely used frameworks are Proctor's implementation outcome framework, which goes to those like implementation, service, and clinical outcomes, or REAIM, which is reach, effectiveness, adoption, implementation, or maintenance. So again, it doesn't matter which outcome framework you use, just pick one to put it there. And then the proximal or distal endpoints for your patients or program is the final component framework. So the way that these kind of linked together is that there's sort of like some horizontal integration here, that we have implementation determinants that lead to implementation strategies that lead to the implementation mechanisms. And so if you do education and you increase knowledge, your outcome will be that you have more knowledgeable clinicians. That's an implementation outcome, perhaps. It doesn't necessarily mean the clinicians are doing anything better. So you would still need to measure implementation fidelity and reach to patients. If you educate the patients, they might know about your intervention, but you still need to measure either patient knowledge or patient reach. So you would need those implementation outcomes here. And then there would also be a horizontal path that you've got a clinical intervention and the intervention mechanisms there, and that could lead to clinical outcomes that you might be measuring in your project, and you might not be able to measure some of them. So in my exercise and PT example, if people with Parkinson's exercise, they might have symptom management for Parkinson's, and so you could measure the Parkinson's disease severity score, the MDS, the UPDRS. But if you could just help people increase exercise, and we know that exercise improves symptoms, then you might not need to measure the distal patient outcome in an implementation project, but you would reference that you know that it is there. It's just that it might not be something you're measuring. So the determinants, though, is kind of where that like horizontal line kind of gets messed up, because you might have determinants kind of, you probably need a big triangle here if you can see my cursor on the screen there. The switch to the like all of the determinants can go to the implementation outcomes. So I want to contrast how the implementation research logic model connects things, which really comes down to being a really theoretical thing and just making sure that you're planning for all the contingencies based on the determinants. But if you were really trying to think about what am I going to do in my implementation project, then you need to be using an implementation process model. The knowledge to action cycle is the one that I have pictured here, which is one of the more widely used ones in rehabilitation. But I mentioned EPIS before, which is exploration, preparation, implementation, sustainment. There's a 3-stage one, the query model that the VA put out. Whatever your process model is, it's walking you through the steps of implementation. And what we have here is kind of on the left is everything you're doing pre-implementation. On the right are the things you're doing during implementation and your monitoring. And if you have a process model like this, you can also integrate those same implementation frameworks into the implementation process. So here we have the consolidated framework of implementation research, which is something that you'd be looking at when you're assessing the barriers and facilitators. You would have the ERIC and the C for Eric matching process to do your expert recommendations for implementing change here at the top, and then you'd have your evaluation frameworks here. So as you're thinking through like your process of implementation, you're walking through using all of the different implementation frameworks, and then your process should match going back to your IRLM that you would be considering everything there. So I want to pause for just a second before I provide examples of IRLMs in different contexts and just see if anybody has any questions about the frameworks and how they integrate into the implementation research logic model. I know this is like just a lot of theory stuff. Okay. Then
Sorry,
thanks,
Miriam.
Courtney. Yeah.
I have a quick question. Can you speak a little bit more about changing the IRLM to be more of a communication tool with clinicians?
That is a great question, and I'm going to defer that one to when Kristen does her presentation.
Excellent.
And how we walk through it when you're talking with clinicians and breaking it up.
Great, thank you.
Great. And actually, the slide kind of starts that. And the first is just, how do you read an IRLM? Most of the time, we read left to right, right? We started the determinants, and the determinants are what come first. But in a research study, you can't understand determinants without knowing what your intervention is. So I'll be talking here in terms of clinical interventions because it's a rehabilitation audience. So the first thing I read when I'm reading an IRLM is the clinical intervention. What is the evidence-based practice or measurement or innovation that you're trying to implement, and what's the description of that? And then now in my IRLMs, I actually have a second box here. That's what's the mechanism of that intervention and what is the clinical and patient outcome. So I kind of start at the bottom, and then I go through my implementation and my clinical outcomes. And I think you could do clinical intervention, and without even thinking about what outcomes you're trying to measure with them, you could go back and study the determinants of the intervention. And there are tons and tons of rehabilitation projects that are like, what are the barriers and facilitators to this clinical intervention? So they're really just doing the determinants and clinical intervention piece. But when you're doing an entire project, I like to go to the outcomes first and think about kind of what are the clinical outcomes, and then I work my way up. What are the things that have to come? In order to have people with Parkinson's improve their Parkinson's symptoms, they actually have to exercise. So I'm going to have to measure how much they exercise. And in order for them to exercise more, they're going to need to, my hypothesis is that they need to have some visits with a physical therapist. So how many visits did they have with a physical therapist? And so I work my way up the outcome column to fidelity. And then like those visits with a physical therapist need to be done with fidelity. The physical therapist needs to cover the things we want them to cover. So fidelity goes in the implementation outcomes. Once I know what I'm trying to change and all the things I'm trying to change, then I go back and I do my determinants, because here it's not just the determinants for the clinical intervention, but I'm thinking about what are the determinants for what's going to make the physical therapist do the intervention with fidelity. And I'm thinking about all of the outcomes I'm trying to change. From there, I loop in the implementation strategies, and then I think about their mechanisms, and I make sure that I have now selected implementation strategies that are going to actually change the implementation outcomes that I have. So this is my order of operations for reading an IRLM. So just a couple examples, and I wanted to kind of provide an example here where this is the one that I talked about already. That is an example of using an implementation research logic model in reporting. So while we were working with JD Smith and Dennis, we kind of put our project into an IRLM. I have used it in grants. So this is an IRLM from my R01 where, because I had already done a lot of work, I'd done implementation studies, I'd done a sustainment study. Now we're looking at scaling it to different sites. And I could hypothesize a fully specified implementation research logic model that I said was going to need to get changed a little bit for my 2 different sites. But I had one specified. In an earlier project, you might not know what your implementation strategies are. So if you're using it in a grant, you might use it like this. And this is an example that was in a successful R01 that was funded by AHRQ, where it ended up being funded as an R01. Our first example, or our first version of it, was an R21, R33 application. And we basically just said, we're going to figure this out. We already know the determinants, but we're going to figure out the implementation strategies and the implementation mechanisms throughout the course of the project. So that's kind of examples of reporting and in grants and project planning. So I wanted to share that there is an ongoing review right now of the IRLM use over the last 5 years since it was published. And that's going to be really exciting when it comes out. So far, there's over 300 articles that have cited the IRLM, and over a third of them include a completed IRLM as a part of the publication. It'll be really interesting someday to be able to like synthesize all of this information. They have primarily been used in planning and reporting, and just in some of the chit chat before the meeting, it sounded like planning is the way that project planning was how rehab researchers were using them mostly. Many, though, lack a description of community engagement to inform the development. So it might just be the researcher thinking through the steps and putting it into a grant rather than doing all of the interviews to get determinants. And that may or may not be appropriate in different studies. I know we're hoping to see more use of community engagement to build it. But as I said before, it's just really hard to get the community or clinicians reading it. And then a lot of the ones that are published don't include that linking, that like color coding or superscripts linking the determinant to the strategy, to the mechanism, to the outcome. So some of those things I think are going to need to be changed and edited as the IRLM progresses. And if anybody has any feedback, I'm happy to take that as we go through discussion. So key takeaways from my side are that the IRLM may be most useful in planning, like grant writing and project preparation, completion of a pre-implementation aim, and reporting studies. It does, we believe, enhance the rigor of implementation research and communication among implementation scientists and other researchers, but it does require adaptation for use with clinicians and for outlining an implementation plan or process. It's not synonymous with an implementation blueprint. So I am going to stop sharing so that Kristen can take over sharing, but while we're doing that, does anybody have any questions?
I was just curious, Miriam, I guess like based on like the development or maybe any feedback you've gotten when you've submitted grants, has anyone ever like a grant reviewer provided feedback that maybe like what you're implementing should be included in the model? Because I guess like looking at it, it's like a lot of information, but then it's like, but what are you like? What
I always
exactly
have.
Okay.
Where
do you
so like
include
that
then?
Yeah, so that's like the box at the bottom, the clinical intervention or evidence-based intervention, and outlining what it is.
Okay.
So in my grants, I have in the R21, R33 application where we had it just gray, that one didn't have the intervention in the implementation logic model, but the intervention was well described in the grant. Like it had a section that was like intervention. So that one did not get any feedback on it either.
Okay.
But I do like including it in my models because I think it's
like
important.
looking at it's like so much information, but then it's like what's like the primary goal? I guess
that was like the first thing in it that I was like, this just doesn't make sense to me because it needed to have that box in it.
Cool.
Okay, I'll pass it off to Kristen to share this like really ACRM specific example of the rehabilitation treatment specification system and how it's being implemented at Shirley Ryan AbilityLab.
Thanks, Miriam. So as Miriam said, we're going to be talking through the application of the RTSS into the IRLM, and I'm going to advance my slides. So I know several of you who are in attendance know what the RTSS is, but just to level set for everyone, RTSS is a theory-based framework that can be used across disciplines and diagnoses to better specify treatment interventions that we're doing in rehab. As clinicians, we measure progress really well with outcome measures. And so we know their start and we know patients' end, but we really don't know that sauce in the middle of what gets a patient from where they come into us to where they discharge. And so our organization identified this as a priority to improve clinicians' decision-making and really felt that the RTSS could help better specify that kind of middle sauce area. And so as Miriam kind of outlined, that is the first thing we did, is that we wanted to define our intervention. And so that's improving clinicians' decision-making and the selection of therapeutic interventions by using the RTSS. And I will say that we had kind of an organization-wide implementation effort for this that across all disciplines, so PT, OT, and speech. But as we go through this, you'll kind of see at times we are as one group at an implementation level, and then we then divide off and we are having kind of 3 parallel implementation efforts. And you will see most of that information I'm going to talk about is PT related or GATE because I'm a PT and I've been intimately involved in the process over time. And so that's going to be kind of our flow today. And why did we choose this? Really, it allows for greater specificity in terms of what happened during a session. And we're hoping that it improves clinicians' communication, not only within a discipline, but across disciplines, that it's more informed patient care decisions and also improves our understanding of what is that sauce that's happening in the middle that's making our patients better. And that could be done through being able to actually extract what happens in sessions in a better way. So as Miriam said before, our kind of first or second step is going to be to verbalize the outcomes that we're going to use to measure success. And I apologize if this is small on your screen. But we had 2 different ways we were measuring fidelity. So we wanted to see the percent of patient charts that we had that clinicians selected a target that aligned with an outcome measure. So when we look at our GATE targets, we have kind of balance-related GATE targets and biomechanical related GATE targets. And we'll kind of go into this in our assessment. But we want to see that if a clinician is choosing a balance measure, that they've chosen a balance-related GATE target as well. So we'll look at that. We also want to see, like, a clinician can select a target, but what they actually do, does it make sense? So that was our other thing to kind of look at from a fidelity metric. Clinicians will have the option to document in the RTSS documentation, but they also could document their session outside of that documentation. And so we want to see if clinicians are actually using this with patients that are appropriate for it, and are they choosing to do it? And so we'll look at that in terms of how many patient charts have used RTSS documentation, and then also how many clinicians have adopted this and are using it. We'll look at that not only in the immediate term, but also sustaining over time, 6 months to a year. We have a list of targets that's probably 45-ish long, and our anticipation is that there's going to be targets that are more frequently used than others, and so we want to specify and understand which of those targets are used most frequently and meaningful. And then, we still care about our patients getting better, even though we've kind of outlined this framework of thought. And so we want to see our patients and how many of them are reaching clinically significant improvements as measured on their outcome measures over time. So then we jump over from the IRLM's kind of right-hand column, that is the outcomes, over to the left-hand side of understanding our implementation determinants. And the way we chose to do this was to put together an expert consensus group. That included organizational leaders, department managers, researchers, and experienced clinicians from all levels of care. And we had a discussion, and each of you can kind of see for the inner setting domain here, we had each of the determinants, and then we would rate them on a Likert scale after our discussion. 0, we didn't think was going to be a barrier for us, and 5 being a significant barrier. And so for each domain, we summarized barriers were 4 to 5, and then 0 to 2 were facilitators. And just looking at kind of the scope here, we felt like the predominant place we would need to work would be in our inner setting. So across our organization, those are definitely more barriers than facilitators that we anticipated to start. So what did we do after we had this group that we found all these barriers and determinants? We needed to generate our implementation strategies. And so as Miriam mentioned, we took CFIR, our Consolidated Framework for Implementation Research, And we used the query matching tool to identify our ERIC strategies. And I will say we did this process 3+ years ago. I'd have to actually look back. But at the time, CFR 2.0 had just come out, and we felt most comfortable with 1.0. And so that's why we used 1.0, is because it actually is a few years ago at this point. So in order to generate our strategies, we looked at each domain. So we looked at the inner setting, we looked at the outer setting, we looked at the intervention characteristics, we looked at the individuals. And we looked at those individually as well as a whole. And then that generates a lot of options of ways that we could approach this implementation effort. And really, we needed to review those strategies across our group and really determine what was feasible for us and also prioritize kind of what we were going to do. And so we did that. Ultimately, as Miriam mentioned, there's kind of this clustering that you can do. We have 5 different kind of clustering groups where we have using evaluative and iterative strategies. We have developing stakeholder interrelationships, training and educating the stakeholders, changing the infrastructure, and utilizing financial strategies. So we have those 5 groups. And when we look at strategies, we decided to prioritize those ones that are bolded and underlined, at least to start. I think it's something that we didn't prioritize, but really important to mention is that utilizing financial strategies. We didn't pay clinicians to use the RTSS or to trial it or give them a bonus. But something we felt was really instrumental was getting the organizational buy-in and support for this effort. And so we supported clinician time. And not just during their education of RTSS, but also through each pilot phase that we've done so far. Clinicians are supported. And so that, I think, is a financial strategy, though a little bit different than just a monetary reimbursement. Okay, so if we test what we're doing and we're seeing what's working and not, and measuring what we're doing and adjusting for the future, what would we call that process? And I hope in your minds, you've thought, well, that could be a knowledge to action cycle, right? That could be a PDSA cycle too. Or also, if we just use the ERIC strategy, it could be conducting small cyclical tests of change. And so this was what we did, is we kind of knew that we were going to pilot iteratively over time. And in this first cycle, we decided we needed to first build out our documentation. And we knew if this is going to be something that's adopted by clinicians, they needed to have a documentation system that would support them using the RTSS. This was no small feat. Probably, I don't even know, maybe 2 years of work, because not only did we have to specify targets for gait or dysphagia or ADLs, but then we had to think about common language across disciplines. So this was not a small effort and continues to change over time. And so quite an overhaul, I would say, of our documentation. The first time we decided, okay, let's test our work, we chose 6 clinicians, and we wanted to just see, do they understand our TSS? And can they even use this documentation we spent so much time on? And we also said we probably need to get their feedback to understand what we need to change. And then we thought it would be important to review the documentation that they said they'd done and make sure that we thought and agreed with what their thought process was. And so kind of taking some of those implementation outcomes, we looked at only 2 in this first round. We thought surveying clinicians was really important. And so we did the acceptability, appropriateness, and feasibility of the intervention measure. And just looking at pre to post, pre is in orange and post is in that red color, you can see that feasibility increased pretty substantially after they had done their first round of using the documentation, which we were actually very encouraged by. And then when we actually looked at their documentation, so this is looking at how well does their target selection match the outcome measures that they're doing. And really, in theory, they should match, right? If I'm got a balance-related deficit, I should have done a balance outcome measure. And so you can see the balance-related gait deficits, we were looking at, has a Berg balance or a net functional gait assessment been done? And really, they did pretty good there. 83% of the times that we thought that the targets they chose matched the outcomes. In contrast, we thought that those that had biomechanical gait-related deficits and were 10-meter walk tests or 6-minute walk tests being administered, that was a little lower. And so we thought we had an opportunity to improve that part of the fidelity with further education potentially. So cycle 1 is completed, and we need to reevaluate and go back to the left-hand side of our IRLM to see, do we need to change our determinants at all based on what we've learned? And so that's true. We did have to change, and what's bolded and underlined is what changed. And so I think kind of the part that we didn't appreciate enough the first time around was that clinicians' knowledge and belief about the intervention needed some areas to improve. And then also there was a wide variety in the way that clinicians were assessing gait. And we felt like, okay, we need to step it back and go back to the foundational knowledge of how do we systematically and consistently assess gait in our patients. And so that was a big piece. We also realized in this first cycle that we bit off a lot, and we needed to have an opportunity to really trial this a number of times. When we set out on the project, I think we said, we'll do one pilot and then we'll roll it out to our 200 PTs. And we said, oh, maybe not. We're going to need a couple more rounds first. So that was kind of after cycle 1, what we thought we needed to change. And then as a reflection of that, we needed to shift some of our strategies. And those ones that are underlined and bolded here are kind of what we emerged after our first cycle. So we felt like we needed to really stage this, our implementation scale up. We couldn't go from one pilot to full steam across our organization. We felt it was really important to go back and really critically think about our documentation or our education that we were providing clinicians. We needed to provide more kind of educational materials, and how we delivered our education, we thought we needed to change. Clinicians were really strong in didactically understanding RTSS. They could fire off what is a target, what is an ingredient. But really when it came down to talking through a case and being able to apply those concepts and translate it, we saw just gaps, and we felt, okay, we've got to change our approach. And we also felt like the feedback we got from the clinicians after the first round was incredibly valuable. And so we needed to continue to gather feedback and expand what type of feedback we were asking them to give us. So I kind of went through this already. Our cycle 1 feedback, we needed to reform our documentation. Even though we spent a year and a half on it, we missed a couple of targets. And so, we need to reform that. And we need to reform how we're looking at heart rate intensity, et cetera. The new educational materials really focused on some of those gaps that we saw in the assessment of an individual with gait, and how are we doing that? And then we thought we needed to give additional aids. So 1-page cheat sheets and definition pages that were common language across our disciplines. And then to make our training more dynamic and really get into the application-based approach, we integrated quizzes and actually integrated kind of a scaffolding approach where we had a video, watch this person walk and tell me all of the targets you could choose. And then we chose, okay, and now look at the ingredients. And so we really took it by a stepwise approach. And at the very end of training and education, we went to these kind of larger case discussions. Okay, so then cycle 2 comes around and we get more champions from across our levels of care. So we are both inpatient rehab hospital, we have a day rehab site, and we also have outpatient. And so we pulled clinicians from all over the organization, not only at our flagship, but also across. And we also included not only adults, but also pediatric therapists as well. And so we trained them with our new educational approaches. And what we saw was the effectiveness was improved on our education. We thought clinicians are starting to get this and apply this information better than round 1. And we looked at the documentation, we saw better fidelity to correct target identification. So we thought we're on the right track, right? Well, we're not done yet. Cycle 3 is kind of where we're at right now. So we've made additional minor edits to documentation. The scale of the change we make each time we go around is smaller. Little things that we're missing, but it's getting more refined as we go. We also thought it was really important our education of the dynamic kind of case-based discussions started with kind of your classic inpatient rehab who has had a stroke and has deficits across all 4 biomechanical subcomponents of gait. And we thought, well, that's not every patient that is seen in our organization. And so we've got to find more diversity in the examples that we're pulling in and educating clinicians with. And then the other part is we had our champions that we trained in cycle 2. We said, okay, champions, we're ready. We help you with some education here, but I want you to start introducing this to your teams. And that's laying the groundwork for our anticipation. Cycle 3 is going to roll out in the next few months where we're educating across our organization. That's a lot of cycles, way more, well, maybe not a ton of cycles, but way more than I first anticipated when I started this project with our team. And I put this in here. This is just the full implementation research logic model, and we've gone through each part kind of in the flow that Miriam introduced in the order. And I did not talk about strategy mechanisms, but again, it's kind of hypothesized and implied with a strategy. So if I could just jump to what do I take away from working with the RTSS implementation project at our organization and also using the IRLM throughout that, is, the IRLM is edited iteratively every time you go through each cycle as you implement. And then, the strategies that we selected on our first cycle were not what we prioritized on cycle 2 or 3. And that's just based on the determinants changing a little bit here and there. And we've been at this for, I don't know, 3.5 to 4 years, and we're just now thinking about rolling this out to our 200 PTs in our organization. And so I think it's always a good reminder that practice change really does take time, and it's not going to happen overnight. And this is a really good reflection of that. So with that, that is the end of the formal presentation, but I think we'll maybe open it up for any questions people have.
Thanks. I want to go back to Courtney's question, and I don't know if you were gonna, when I saw you come back on camera, Courtney. And I think the way that Kristen went through this is a little bit more similar to the way that I would actually present it or talk about it with clinicians, which is one box at a time. So if I'm working with a group of clinical advisors, let's all just first talk about what the intervention is. What are the core components and the adaptable components? So all they're seeing is the intervention. Then we just talk about the outcomes. Then we might talk about determinants and evaluate them in some way. But I don't normally show that whole thing. In some cases, I haven't, like the example that one of the examples I showed you, the R21 that is now an R01. I don't think the advisors have ever actually seen the entire IRLM. They've only ever seen components of it.
As Kristen was explaining it, it actually, that I was like, oh, this is how it's very clear how you communicate with clinicians. Because I'm like, oh, I get this a lot, like from a clinical standpoint, each segmented box and step by step. Also, you guys, you blew my mind with your suggestion of doing the IRLM, starting with the outcomes. I was always doing it like a book. So that was really helpful. I do have a specific question, especially regarding all those. There's a lot of changes, Kristen, that you talked about doing the RTSS. Are there any tools or strategies you can suggest to track all these changes that you make to your IRLM so that you can kind of keep them
through? I changed and underlined in mine just to highlight what was changing each time. That's been the way that I tracked it. I did not do a cycle 3 IRLM yet, but in 1 to 2, that's how I tracked the changes from them.
Yeah, and I tend to have like, I save iterative versions on, like, I create a slide deck and I just like save iterative versions of it so I can go back and be like, what were we thinking in September? What were we thinking in October? But I don't think right now that there's one established way to do this. I'm working on the paper for that R21 R01 where we're actually going to describe like how long it took us to get the advisors to agree upon an IRLM, and it was like 6 months. We were still tweaking little things, and then we'd talk about the implementation strategies and the plan with the IT people, and then they'd say, no, we can't do that. You know, like they're just like little things that would just keep changing before we landed on the final one. So it was something like 35 rounds over 6 months. That's implementation research, right? If you're just doing a clinical project, you might not want to spend 6 months and 35 rounds to do it. You might just kind of like be doing some of it yourself. This is like a project where the goal is implementation research versus the goal being implementation practice.
I have yeah, I had another
ahead.
question. I didn't want to monopolize the time. One thing I'm still trying to wrap my head around mechanisms. I've read your paper, Miriam, and I'm wondering if there's a different way to word it to like kind of help comprehend what mechanisms are. I'm trying to work on an IRLM right now, so I'm just having a hard time putting stuff in that box.
I struggle with that box too. Right now there's really a research agenda within implementation science to figure out how to specify mechanisms better. So I think that effort is there. A researcher named Kara Lewis, Lewis, is, I would say, leading those efforts. She has had a couple papers on it now, but there's no like taxonomy. Like I said, I actually think in some of these that I'm making, that when I start using the ERIC taxonomy, some of the ERIC taxonomy stuff gets into a mechanism, I think, just the way that it's described. So I kind of think that as all of implementation science is so new, all like the ERIC taxonomy is, I'm sorry, what was that?
Give me an example of like an ERIC taxonomy that you feel like is a mechanism, just to like let's think about it. If you can't think of one off the top of your head.
Oh gosh, I'd have to like
see
if it's in this example. I think education is the most easy one. Like, how does education work? Well, it educates people. But like, I could just like reword that by saying it increases knowledge. But like, the implementation strategy, train and educate, is too broad, right? The implementation strategy is I'm going to do webinars, or I'm going to do an online video, or I think that I would rather specify the implementation strategy a little bit more in my strategy box, and then my mechanism be train and educate. But right now that's not really where the field is. The field is saying the ERIC taxonomy goes in the strategy box. I think that we're going to see some changes to the ERIC, like implementation strategy, taxonomy, and practices and mechanism practices over the next 5 years. We're only just starting to use these terms.
Kristen, I had 2 just specific questions kind of about the inner workings of the RTSS application. I was curious how you determined the effectiveness of the education provided. Was it just like better quiz results? And my second question, just, and this I guess shows my lack of, like, I've read papers about RTSS, but they've been more of like conceptual papers and not actually how it works. And so I was just curious, like, how do you know the target identification is correct? Like how do, because I know you mentioned that was like something I think that improved, and like in my mind I think like it would be subjective based on like the patient, and so like how do you know like the patient that was evaluated and whether the target was appropriate based on like the therapist evaluation, if that makes sense?
Yeah, good question. So I'll start with that one first. So how do we know that clinicians are selecting the right target for that patient in front of them? And, we don't have a direct way because it is, clinical decision, right? What is the best? But we assume that a clinician is strong in their clinical decision-making of their administration of outcome measures. And so we thought that if a clinician is choosing to do the functional gait assessment and they've set a goal around that. We didn't look at that specifically, but if they've done the functional gait assessment, we would assume that they recognize that there's a balance deficit and that then a target should be reflecting of that. So we worked backwards. It's not foolproof. You know, this, I didn't go into this at all. This is the section of the RTSS is the skills and habits, or learning by doing is the mechanism for many of our targets in gait. Speech has dysphagia, and there's an organ kind of function box in theirs, and that is more kind of clearly protocol driven and a clear, you've chosen the right target or not. And so I think it just depends a little bit about the actual intervention, gait versus dysphagia, and figuring out how you're going to assess that.
Oh,
for the education, it was looking at documentation. If we saw that clinicians were selecting targets and then doing something that was completely different, that was a little bit of our inference as clinical providers of the education, as well as our clinicians understanding this or not. And so the other part is in our trainings, as we got around to the champion level of across the organization, we had discussions, and it's very clear if clinicians are understanding and applying this, or are they missing the boat? And we just saw a huge transition from our first pilot phase to that second one, where we really reformed our education approach.
Oh, excellent. Okay, great.
Yeah.
Cool.
You probably could have been more structured, or we could have been more structured in that assessment, but we were not.
What is there? I mean, therapy's unstructured to begin with, Kristen. So it's hard to like pinpoint all those things, but it seems like a great approach.
Yeah, lots of kudos to the organization, I think, for their support of the project and their support of the clinicians' training time and things to make this happen, and the team that's actually doing all the work, the IT team, the clinical leaders. It actually requires a lot of institutional support. So that brings us, I think, to the close. And I don't know, Leah, if you have any official announcements, but I want to say that I thank everybody here for your questions and engagement.
There. I'll just shout out that I think most of the people here are part of our leadership team, and we do have a leadership meeting on Thursday for those that can join at 11 a.m. Central and 12 p.m. Eastern.
Yep, that's all I had. I didn't have anything extra.
Awesome. Thanks, Leah.
Thanks, everyone.
Thank you so much, and Miriam.
Yes, thank you guys.
Thank you. It was very helpful.